13 types of the disease, that being cancer, were previously known to be associated with overweight body types, but now that number has climbed to 18 different cancers. This is Generation Health. Each week we bring you the latest in news, cutting-edge research, and time-tested best practices, helping you live a longer, healthier life. Across from me, PharmD, certified strength and conditioning specialist, Dante DiMatteo. How are you, sir?
Doing well, Tyler. How are you?
I'm fantastic. Behind the cameras, behind the board, our engineer, Josiah Schweinberg. How are you, sir?
Doing well.
My name is Tyler Andrews, and I am the host. Dante, what are we talking about today, man?
We have a real doozy today.
You don't say.
Doozy.
We have a question, listener question regarding migraine with aura.
Okay.
Talk a little bit about that. We also are going to be breaking down an article and a study talking about the link between obesity and cancer.
Right. Yeah. First, a couple of quick hits from the news behind the counter. Regular marijuana users have higher levels of both lead and cadmium in their blood and urine. A new study from Columbia University in New York City found that non-tobacco using cannabis smokers had 27% more lead in their blood and 21% in their urine, as well as 22% more cadmium in their blood and 18% more in their urine. So in both cases, that's a large double-digit increase in both of those metrics and for both of those heavy metals. There is no safe amount of either one of those to have in your body, just to be clear. Both are linked to cancer, as well as things like high blood pressure and kidney disease. As to why these levels are so high in cannabis smokers, the plant itself is a hyperaccumulator, meaning it gathers substantially higher concentrations of those heavy metals from the soil, more so than other plants. But Tyler, I can hear you saying, why are we talking about pot on a show like this? Well, that's a great question. Research also indicates that marijuana use has skyrocketed in the United States with an estimated 42 million regular users in the U.S. alone. So well over, 12, 13% of the U.S. population is a regular marijuana user. So some of you are that. You need to look out for lead and cadmium. Pharmaceutical manufacturer Merck has entered phase 3 clinical trials for an oral PCSK9 inhibitor to evaluate its effect on hypercholesterolemia. I'm not going to say the actual words that PCSK9 stands for because it's a whole lot of letters and I can't articulate them. I've tried multiple times. Feel free to look it up for yourself. But the way this inhibitor works is by interacting with specific LDL receptors on the outside of cells. Those receptors are either looking for LDL cholesterol or they're looking for PCSK9 to tell them, hey, don't worry about it. You've done enough. Merck's trial drug inhibits that stand down order, meaning that those receptors, there are more of them available to pull the LDL cholesterol out of the blood. There are already injectable PCSK9 inhibitors out there, but this would be the first oral medication, making it much more widely available. On a personal note, PCSK9 inhibitors are the first medication that can help those of us with elevated LPA levels. Lp(a) is the genetic or inheritable component of cholesterol that you get from your parents, and there's not a whole lot that can be done with it right now in terms of lifestyle modification or even statins. They just don't affect the inherited portion of it. But a PCSK9, because it's pulling it out of the blood, that actually can affect this. I believe 20 to 30%, something like that. So very exciting. I hope this continues to be safe and effective because it might be in my future before long. Do you guys see a lot of the already injectable version? Do you guys get a lot of that through the pharmacy?
We actually do more and more. So the two most common, I'll mention the brand names.
Yeah.
Praluent and Repatha are the two PCSK9 inhibitors that are most commonly used. They are expensive. They're either used as twice monthly or once monthly subcutaneous injections. So again, mainly why these oral options are so appealing that can be, a barrier for some people to have to do that.
Yeah, the idea of injecting myself, I assume it would be you would do it to yourself or have a loved one or somebody do it. It's not like you have to go to the doctor every month.
Right, exactly. So it's a subcutaneous injection. It's a smaller needle.
Yeah.
So it's not quite as daunting, but it's still, can be an issue for some people.
Absolutely. So
But-
if we can get it in a pill form, that makes it much more available to a lot of people.
Yes, we're seeing that now with the GLP-1 agonists as well.
Yeah.
There are more of those in development as oral agents.
Oh, really?
Ribelsis is available as an oral agent. That's the semaglutide, which semaglutide is the injectable. Ozempic is the injectable version
Yeah.
of semaglutide. So similar concept. But even, kind of just reading this, I know you mentioned that there is the potential for the Lp(a) lowering effect.
Yeah.
While that is huge, the main takeaway is just the oral option versus the injectable option.
Right.
And eventually you see the cost of these things hopefully come down. And again, not that the 20 to 25% reduction of Lp(a) potential that you mentioned, not that that's insignificant.
Right.
It's just that these agents are not technically FDA approved for that indication.
Oh, so this would
which
be
is a
an
huge
off-label use.
Yes, technically.
Interesting.
Now, if you had most people who do have elevated ApoB, let's say, they often have they might have the accompanying Lp(a) elevations.
Sure.
So a lot of that population may go hand in hand. But as of right now, they're technically only approved as second or third line agents as alternative therapy in cases of complete statin intolerance for patients with established ASCVD or FH, which is the familial hypercholesterolemia.
Yeah.
So you may commonly see Dr. Attia using this in his book of patients. And I don't know how maybe they go about the insurance part of that or whatever.
Yeah.
It's not that it's not a useful reduction. Again, looking back at that 20 to 25% reduction, the key here is there are additional agents in development right now, phase 2 and phase 3 trials, that you're seeing 80 to 90% reduction in Lp(a).
Really?
So it's sounding like to really move the needle, that's the type of reduction you're looking for.
That's again, what I want to know about.
Exactly. Not that 20 to 25% is, again, meaningless. It's just that there are some really interesting therapies in development. What they're basically calling them are gene silencers. So there's a couple different classes within that.
It sounds sketchy. I don't know that I want to silence my genes, but
yes. And so the PCSK9s, those are technically monoclonal antibodies, which listeners have probably, they definitely have heard us mention that in different contexts.
Yep.
Again, they're monoclonal antibodies. They end in MAB or MABs. The gene silencers are going to be a totally different thing, totally different mechanism by which Lp(a) is lowered. Novartis is the big company that currently is developing these. There's data expected in 2025. So I know you were. I didn't mean to rain on your parade with the minimizing the reduction in Lp(a) with PCSK9s. So I wanted to make sure that I brought to the table some very promising news.
That is, the inheritable element of it and the fact that it's not affected by diet and lifestyle is what's concerning to me as somebody who has hypercholesterolemia from my family. I can diet and exercise all day long. I take red yeast rice and there's all kinds of things I can do, but that inheritable portion is not going to change this side of some sort of crazy, fun, new medication. Right. And so it's anything that can change it is good, but I didn't realize that there were things that effective.
Yes.
Hopefully in the works.
Yeah. The phase 2 study for pelacarsen, it's called. It's had all types of different names up to this point, but pelacarsen, it sounds like, will be the generic name. The phase 2 study showed an 80% reduction in Lp(a) at the top end in those with a baseline Lp(a) of 224-ish nanomoles per liter. So it's a massive
224. Okay, that's way more than I had. So I guess it's not as bad as I thought.
Yes, and that the other goofy thing with a lot of these, lab panels, especially when you're looking at a value like Lp(a), I didn't realize how much controversy there was in the actual notation or the actual unit that they use. So you got to watch for millimoles per liter. You got to watch for milligrams per deciliter. You got to watch for nanomoles per liter, and the conversion factor is not necessarily a one-to-one thing either. So there's layers within the layer.
That's the fine
man.
print that they don't give to you, I think.
Yeah.
That's why, lab work, you got to have
make sure we're all speaking the same language.
Definitely, especially with something like this, which I'm definitely interested in hearing more about. The other thing I didn't want to ignore that you said, you mentioned statins at the outset. In looking at some of this data, statins, they have a range of effect on LP(a).
Okay.
Ranging from a little bit of a decrease to no effect at all to actually raising it slightly.
Oh, geez.
So there's even nuance within the kind of the function of LP(a) in the body. So there's lipid metabolism, man. We always
it's a big topic.
It is, and then also how the other thing with the reduction in LP(a) when just using PCSK9 inhibitors, all of that data is basically what they've done is it's a post hoc analysis. So these were not, forward-looking statistical analyses. These were basically analyses that were specified after the data was already finished.
So they figured it out after the fact.
They figured it out after. And not that that's rendered useless in any way. It's just that's why we can't slap an FDA indicated approval on it, because somebody after the fact looked at this data and said, well, hey, we're seeing this effect on LP(a),
right?
But they can't quite tie it, directly to a meaningful outcome with that. It's pointing in that direction that there's obviously going to be some reduction in the actual cardiovascular endpoints that they're looking for.
Sure. All right. Well, it's so funny. These are meant to be quick conversations about, hey, here's what's happening in the world of pharmacy, and it always turns into an actual conversation.
There's just
fun.
So much there. So much there. We have that cholesterol bias too.
We do. We talk about it a lot. If you want to know the details on cholesterol and why this is such a big deal, episode 13, one of our most popular episodes, it's a deep dive in cholesterol. We're going to have to do another one at some point in time because the data keeps expanding. Mm-hmm. So anyway, we're not there yet. Today, we have a question from Diane. She messaged us on Facebook. She said, "Good morning. I recently had an absent migraine with aura. It kind of makes me feel like I am having a stroke. I can't speak correctly. They don't happen often, but are very scary. Any advice? Can it be hormonal? I'm 58, and this is new for me. Look forward to hearing from you." Wow, that is terrifying. Mm-hmm. I've heard of migraines. I've never heard of a migraine that leads somebody to feeling like they're having a stroke. What is this? What are we talking about here?
I certainly want to get to directly addressing her question, but you're right. We should definitely discuss some quick definitions, some background. We have not talked about migraine yet. So broadly speaking, migraine broadly in a broad sense is one of the most common neurological disorders involving 14%-ish of the population.
Okay.
So within those patients, roughly 20% experience transient neurological symptoms before the actual onset of the headache, which gradually develops over 5 minutes or so and typically lasts less than 60 minutes. And
okay.
So that little categorization would be the migraine with aura.
Okay.
Those neurological symptoms.
So roughly 14% of the population has migraines, and of that 14%, about 20% have them with aura, which is to say some sort of transient neurological symptom.
Yes.
Okay, what is that? What are we talking about? A transient neurological symptom?
Yeah. So when we're talking about aura symptoms, they're most frequently visual in nature. So over 90% of those have a visual component. So you have trouble seeing or there's some sort of distortion. There's also other sensory symptoms. So pins and needles are very common. Hemiparesis is another one, which refers to the inability to move one side or the other of the body, which it sounds like in Diane's case, she's vaguely referring to.
Okay.
And then there's also speech deficits as well. So it obviously sounds like it's very similar to stroke symptoms.
Yeah.
And so that's why it's very important, to discuss all of these different elements.
Okay. So we want to stress, we don't diagnose people on a podcast. So you should get this checked out by a doctor, especially if it feels like a stroke. You should probably go see a doctor like now. But assuming that's happened, where do we go from here?
Yeah. And even just to talk a little bit maybe about the hallmark symptoms that we can distinguish. So for example, if you're having an experience like this, if it fades away in that 60-ish minute realm, then you know this is looking more like an aura.
When you say, are you talking about the not the pain, because the migraine sticks around? You're talking about the visual or hemiphoresis. Is that what you're calling?
Yes, I guess. Right. If it's more of this gradual onset and then it's a gradual tapering off, that sounds more like a normal aura, so to speak.
Okay.
The persistent auras, the ones that last for a long time, that can be a red flag. The ones where there's one eye affected, potentially, there's a visual, like a very distinct visual disturbance on one side or the other, that can definitely be looked at as a red flag as well. And then looking at this link with stroke a little further, it's a complex link, but there is a link in and of itself between strokes and migraines.
Oh.
Especially migraine with aura. And so this isn't to scare, this isn't to say that you're doomed if you have migraines with aura, that you're eventually going to have a stroke one day. It's not to say that, because as of now, there's not really anything that we're doing, I think, with this link clinically. It's not necessarily changing your treatment, for looking at your stroke risk factors, let's say.
Right.
But again, if she's going to talk to her doctor, obviously, about this might allow her doctor to hone in on some other risk factors that she may or may not have.
Okay, but you're saying like a doctor's not going to get confused. A doctor's not going to, you're not going to go to the doctor and they're going to go, oh, well, it might be a stroke or it might be they're going to know one way or the other. Okay, so that adds some.
So we got that first order business
relief.
Out of the way.
Yes. Okay. So assuming that it's just a migraine, how can we help her? Yeah.
The other thing within her question I wanted to highlight, at least so we're on the same page. Absent migraine, at least from what I could tell in some of the research, is synonymous with silent aura. It's occasionally or previously was referred to as an ocular migraine. So just want to make sure we're on the same page.
Okay.
It's been called a bunch of different things, but basically it's an aura. It's a migraine with an aura without the actual headache. That's when she says absent migraine with aura, that's the way that I interpreted it.
Okay, so that means there may not be the pain element. It's just the speech impairment or the visual impairment or the pins and needles.
Exactly.
Oh, okay.
Yep.
Fascinating. I didn't even know that was a thing. Okay. So what are we? There's different types. You said there's.
So in looking at this subtype specifically, there is a lack of evidence regarding treatment specifically aimed at this migraine with aura subtype. So migraine with aura ends up being treated very similarly in a lot of cases to the cases that have headaches present. Or we see that some patients don't do anything at all because they have this strange aura. They know it might last this amount of time. And then they say, the heck with it, I'm not going to take any ibuprofen, or I'm not going to take the abortive treatments or the treatments that stop the migraine, like a triptan. They'll skip those since the headache part itself is missing.
Since it's not actually deeply painful, it's merely inconvenient for a little while, and then they can get on with their day.
But
fair enough.
But there are definitely still some things you can do, and I still don't think it's worth ignoring.
Yeah, no. Any kind of neurological condition like that, you want to make sure that there's not something weirder going on. Okay, so what treatments are available for people that are having these?
So if we look at some categories to run through with migraine in general, and a lot of this discussion is going to have some overlap between the subtype of migraine that has the headache, the subtype of migraine that is missing the headache. So like I said, the literature is sparse with some of that information.
Right.
So I'll do my best to delineate. But again, just to...
So for the most part, assume that it covers all of it.
Yes.
there may be some where it's not.
Some overlap.
Okay.
Of course. So looking at these categories, we have prophylactic or preventative treatments. We have acute treatments or treatments that you can employ when you notice the symptoms. And then we'll sort of lump the supplements and such into other options, which can either be used prophylactically or they can be used acutely. So looking at the preventative options that do have some evidence, at least these are some things that she can mention to her doctor. The anti-epileptic drugs seem to be very effective in this realm. So we have Lamictal and Keppra are the two big ones. They are generally well tolerated. They've been around for a long time. I know some people will, have the tendency to shy away from those, but nonetheless, those are options to at least ask about.
Right.
Topiramate is another option, which seems to fall more in the category of the headache subtype from what we see. Still worth mentioning. That is used for a handful of other things as almost like a double edge if she does have some coexisting conditions.
Sure. Yeah.
Switching gears in this subset of preventative options, we're looking at daily aspirin.
Okay.
And so looking at these options, it'll start to highlight maybe what's happening at the level of the brain. Like, why is this happening?
Right.
And so the mechanism of the medications can indicate maybe what's happening physiologically or pathophysiologically. So the first two, the anti-epileptics, there's some sort of wires crossed.
Right.
With the brain that these are helping to combat. It's much more complicated than that, but we'll just just leave it at that. Aspirin is almost reflective of some sort of vascular issue maybe that's happening in the brain. And some of the research almost refers to the underlying causes potentially as almost microemboli or like these little clots.
Wow.
That are in the blood vessels. I would be curious to, learn a little bit more about that.
Yeah.
But nonetheless, highlights maybe why aspirin use, daily low dose aspirin, has a role in this setting. The other option kind of goes along the same path would be calcium channel blockers. Those are typically used as blood pressure medications, blood pressure lowering medications. Essentially what these are vasodilatory in nature. So they open up the blood vessels a little bit, sort of connects us to the issue or the uses that aspirin has.
Right.
There's something going at the level of the vasculature in the brain.
And it seems, am I right in thinking that those would be the ones that are more likely to tie in with stroke?
Yes.
Okay. That makes sense.
Mm-hmm. Their beta blockers are often used as well. Another blood pressure lowering medication. These calcium channel blockers seem to have less of an issue with side effects for the most part.
Always good.
So that, I would say, covers the preventative medicines.
Okay.
And then if we look at the acute options.
So while it's actually happening.
Yes. And again, we're still biasing this towards the aura specific subtype, but some overlap.
Yep.
Magnesium.
Yep.
Is an option. What I primarily see in the research talks about intravenous magnesium sulfate.
Oh, wow.
So if you're in the hospital, I believe that this is a pretty commonly used option to try to just stop a migraine with aura in its tracks. I found that interesting. We'll talk a little bit more about magnesium orally later on.
Mm-hmm.
Ketamine is another option. This is being looked at a little more commonly now in actually some small randomized trials. It's obviously an off-label use, and it's primarily used intranasally. And then intranasally, very intranasal, intravenous, obviously what you can deduce there is a very quick onset to action.
Right.
The other options, I found this one interesting, furosemide, which is another blood pressure medication. Now this is more specifically tied to the role of potassium in some of the issues underpinning the cause of migraines. Mm-hmm. And so this reduction in potassium that furosemide causes is thought to, maybe lead to its therapeutic benefit.
Maybe avoid bananas.
Avoid bananas. Yeah. This is bananas, bro. The last option I want to at least mention is it's called single pulse transcranial magnetic stimulation.
Ooh.
And so it's almost this, it's short for it is STMS. And it's almost like this device that goes on your head or the back of your head that is basically non-invasive brain stimulation. So it's not really widely available at this point, but it looks like it has the potential to help either acutely and in the prevention setting. But it's not like a virtual reality device that people with migraines have sitting at home.
Right.
Throw one on.
It's like Doc Brown from Back to the Future. He's got that big helmet on. 121 gigawatts.
That's right.
That's not a thing. Don't look for that at your local pharmacy or ask your doctor for it, because that's not a thing.
So yeah. So those options, I think they're worth mentioning, worth asking about truly.
Okay.
Now I think we saved the best for last, as far as some things that you can do in terms of lifestyle. And then also I know I mentioned we were going to talk about other options in the form of different dietary supplements that are available that actually have evidence. So there's some light at the end of the tunnel.
Yeah.
And this is where it gets a little more gray as far as, are these for the subtype with the headache, subtype without the headache? It's mixed. It truly is mixed. So looking at these options, the first one is riboflavin.
Okay.
That's vitamin B2. It's useful more so in prevention. So we see individuals have a true reduction in the frequency of their migraine attacks. It's most effective at 400 milligrams per day.
Okay.
I think it's relatively inexpensive. It's a no-brainer in my opinion.
Yeah. If this is causing you issues, that's something you should probably just go ahead and add in.
Yeah. And especially if you've made it to this point and you are maybe falling more in the headache subtype, this is a very viable option.
Okay.
In addition to that, CoQ10 is another one that is often found in tandem with riboflavin in different migraine products. Can also reduce frequency. There appears to be no additional benefit for migraine, specifically above 300 milligrams a day.
Okay.
We have it in 100 milligram. We have it in 200 milligram. So somewhere in there would be fine. But there's also there's some quality evidence there for sure.
Sure.
Magnesium, which I was actually surprised to find, given how frequently it's recommended for migraines. There's actually less solid evidence for its use in either one of these or any one of the migraine subtypes.
Interesting.
So it still can be beneficial. I just don't think it's quite as strong as the first two we mentioned. Now, with that said, for what it's worth, the Canadian Headache Society still recommends magnesium for prevention. So,
well, and if it's used acutely when there's a problem, it would make sense that having just a higher tonic level in the bloodstream would be an improvement.
That's a good point. But that's what they have trouble parsing out in the research. So those sort of very
so it's not proven.
Yeah, it's tough.
Got
it's
it.
tough. So they're still in most of these guidelines, most of these papers, they're still recommending if you can increase magnesium by way of your diet, definitely continue to do that, because they're just really not sure if the magnesium helping is a function of low magnesium status or something at the level of the brain. It's just less. There's just less clinical oomph behind it.
Yeah. Fair enough.
The Canadian Headache Society also recommends CoQ10. So I think that's reason enough to at least consider it. Another relatively inexpensive option. Now, our combination product, Migraines, has riboflavin. It has magnesium, which we mentioned, two big ones. It also has rosemary and curcumin as well for the anti-inflammatory properties. I would still suggest adding some riboflavin to that. You can also add the CoQ10 to it.
Yep.
So take a look at that product. I think that's maybe a decent place to start if you're dead set on doing something. And then you can always add some riboflavin. You can always add some CoQ10.
Makes sense. Lifestyle, is there anything else beyond supplementation? Is there, making sure that you're getting enough sunlight or changing diet radically or anything like that?
There are. The one that I wanted to hone in on It seems to be popular on social media as well in talking about this specifically, but the role of exercise in migraine treatment and migraine prevention seems to be pretty black and white.
Interesting.
Yeah. So much of the existing evidence at this point suggests that different forms of exercise, they play a role in reducing frequency and severity. Now, with that said, the questions that I had were, is there a specific type of exercise that works better? Is it resistance training? Is it just cardio? What about the intensity of the resistance training? What about the intensity of the cardio? It's just a lot of, I think that's an example that we need more granularity as far as what can we package up and tell somebody to employ, not just exercise more.
Yeah.
Fortunately, there's a study from 2022, a meta-analysis, again, that's making its way around social media, that has put exercise, all modalities, in a very positive light in this context.
Okay.
According to that meta-analysis, the strength training was most effective in the average reduction of migraine days per month.
Awesome.
So that's how they looked at it. So strength training had an average reduction of about 3.5 days. High intensity aerobic training had a reduction of about 3 days, 3.1. The moderate intensity aerobic activity had a reduction by about 2.2 days.
Okay.
So you can see it sort of taper off there a little bit, all three of those categories were more effective than placebo, more effective than a couple of the current medications that are being used, amitriptyline, one of them, topiramate being another. So
wow,
it was a pretty intense look at what the existing research is out there. So it was nice that it incorporated all of those sorts of things.
Now, was that research done on migraines with aura or migraines in general?
This was more in general.
Okay.
And so even looking through some of the individual papers, it of course mentioned aura.
Right.
A little bit, but this wasn't
a specific thing.
Yes.
So, but that's maybe not specifically for Diane, but
yes.
But for everyone in general, if you're experiencing migraines and you want to have fewer of them, which I don't know who wouldn't want to have fewer migraines, you need to be exercising first and foremost.
Yes.
And and maybe you are going to get to this, was there any, if it was greatest benefit from weight training and then second from aerobic activity, did they try combining them to see if it had a greater capacity or greater relief, or was the 3 whatever day reduction, was that kind of the cap?
In this context, it was just, they were individually compared.
Okay.
So, but as always, when we zoom out and look at the kind of the bigger picture,
yeah,
why do one or the other?
Right.
It's still most beneficial to do both.
Yeah. Yeah. So
100%. So even though this isn't somebody's, permission to say, well, I'm just going to lift now.
Yeah.
I'm just sticking with resistance training now.
Fair enough.
So yeah, right. You got to zoom out, it's easy. Just that's a prime example of kind of honing in on the minutia. But if you zoom out, there's 1,000,001 other things that comes from doing both of those modalities.
That makes sense. So it's a question that doesn't need to be asked. Stop it, Tyler. Just move on.
I actually liked that question because ultimately then how does somebody package this up and make actionable change or implement something new based upon that? Because you look at this and you're like, well, if migraine is my particular focus, maybe I just need to focus on strength training for now, which is fine.
Right.
But in general, I do think that the paper actually had some useful commentary in the discussion with respect to laying out a training week. So,
oh wow, okay.
So me talking is no substitute for maybe just going in and looking at how they outlined a week of training, a week of doing some resistance training, a week of doing conditioning.
And we'll have that link down in the show notes. So anybody interested, you can go look at that and see specifically what they're talking about, what we're talking about here.
Mm-hmm. But in general, their recommendations coincide with the guidelines that we often reference.
Go figure.
So that's kind of how they, yeah.
So wait, this is becoming the You Should Exercise show.
Mm-hmm. Almost like every show.
That's it.
Yeah. And so they got down to how many reps and sets,
Wow.
when to progress, when is it okay to add weight, how intense should your cardio work, what should your high intensity intervals look like. So they
all in the research about migraines.
They did talk about this in the discussion, yes, because they looked at the different designs of the studies that went into this meta-analysis.
Yeah.
They looked at the average time that the individuals in those studies exercised, and then so they used that, plus they coupled it with the exercise guidelines to sort of make these recommendations, which I think was fair.
That is cool.
So, for example, in a week of strength training, let's say, if that's your focus, it basically is 2 days a week of strength training, and then in between each of those days. So you never strength train 2 days in a row, but in between those days, they call it an active recovery, which I don't know about that terminology. I used it a lot, but maybe part of that was just neurotically wanting to train all the time, basically. Well, I'm off today, but I'll just call it active recovery. I'm still going to do something.
Sure.
But active recovery really, I think in this case, just means even though you're not in the gym, move around, get outside, but almost have it at that sub that threshold that would maybe constitute exercise.
Well, and it makes sense that if you're strength training 2 days a week, then you could also do cardio 3 days a week on the other days.
Right.
So that you're doing something every single day to stay active, to make yourself healthier, to live better and longer. But it is not.
What zone? What zone are we talking about?
Hey, now.
Yeah.
More in a previous episode. Check out the cardio zone.
Yeah, the high intensity, they even talk about what percentage of VO2 max to start with. So even if you're going to do some high intensity, it was recommended to start at 50 to 55% of your VO2 max.
Wow.
Progress it to 80 or 90% of your VO2 max. So if you're somebody that has migraines and you also know your VO2 max and you have heart rate data and you're that into it, then it's all there.
But
they also make sure to mention how to use the talk test, which is no different than the recommendations that we mentioned before. They mentioned the rest intervals, work to rest intervals, basically, if you're doing high intensity. So it's 1 minute. It was 1 minute of, that above the threshold of the talk test.
Right.
Talking in 1 to 2 word sentences becomes a challenge. So 1 minute of that. And instead of resting for 4 minutes, you just kind of go into that zone 2 or that moderate range for 4 minutes and try to sustain that. After the 4 minutes, go back to the 1 minute of more intense exercise. So
this is a doozy.
This got just about migraines than I expected.
Diane.
Yes. So so it makes sense. There's this really detailed meta-analysis. The studies within that meta-analysis were pretty solid, very specific training regimens. A lot of them lasted 8 to 12 weeks. It was just a very kind of sounded like a exercise, you get an exercise program, you follow it. It sounded like they at least tried to, by the end of the paper, say, okay, now here's a training program, basically.
That's awesome. Well, if you are listening to this the week that it comes out, we are about to have our fall sale. This is our big sale at the website, askjoedimatteo.com, askjoedimatteo.com, where you can get magnesium or the Migraines or any of those other products that we talk about all the time, some protein, all those things. 20% off for the next couple of weeks. You'll need code FALL20, FALL20, FALL20 at checkout. That'll get you 20% off of all of our essentials on the website. If you are listening to this the week that this drops, the week this comes out, you are getting access to that sale before anybody else.
Whoa.
FALL20. All right, that's it. That's all the talking we're going to do about that. This show was brought to you by you. So go check out the website and buy some product for us. All right, next up, cancer and obesity. It isn't breaking news that obesity is linked to a whole host of negative health outcomes, nor that those health outcomes combine to a substantially greater risk of death at any given moment. But researchers in Spain have added even more clarity around the link between being obese and cancer. So this article was in the New York Post. It said in all 13 types of the disease, that being cancer, were previously known to be associated with overweight body types, but now that number has climbed to 18 different cancers. And the risk of developing cancer begins when people are young, between the ages of 18 and 40. The researchers looked at the electronic health records of more than 2.6 million people in Catalonia, Spain. The people were 40 years old or older in 2009 and were then free of cancer. But in 2018, just 9 years later, over 225,000 of the people, study participants, had been diagnosed with cancer. That's almost 9% if you want to do the math. The researchers also sorted the data by including decades of the participants' health records showing a BMI of 25 or greater, which indicates that a person may be overweight or obese. The results of the study, published in Nature Communications, revealed that having a BMI of 25 or greater led to a greater risk of developing 18 different types of cancers. Specifically, the researchers found that those who were overweight in early adulthood, between the ages of 18 and 40, had an increased risk of cancer. The people who were overweight or obese for a longer period of time also had a higher risk of developing cancer. Finally, those with a much higher degree of obesity in their youth had a greater risk of cancer. In addition, the additional types, additional to the 13 that were previously known, the additional types of cancer that the researchers linked to obesity or being overweight were leukemia, non-Hodgkin lymphoma, head and neck cancers, and bladder cancer. And for those curious, the original 13 were endometrial, esophageal, gastric, cardia, liver, kidney, multiple myeloma, meningioma, I can't say that word, meningioma. There we go. I'll get it eventually. Pancreatic, colorectal, gallbladder, breast cancers, ovarian, and thyroid. So that's a long list of most of the major cancers out there. If I understood that right, the younger you are, the younger you become overweight or obese, the longer you stay overweight and obese, the more overweight or obese you are, the greater your risk of cancer. Is that correct?
That's correct.
Wow. So, one more reason piling on here that tackling this issue is super, super important.
Yeah, like we see with, hypertension, hyperlipidemia, or just the two that come to mind.
Right.
That's why there's much more push to intervene earlier with those as well.
Yeah.
Because it's not just it's not just your blood work in and of itself or your one blood pressure reading. It's just it's those exposures over time.
Right. It's not that, you were overweight for 1 month, therefore it doesn't matter, damage is done. It's the longer you are in that status, the more of that status you experience. Okay. So helping people talk about it, we're talking about BMI, which always gets squirrely. They were talking about a BMI of greater than 25. Definitionally, that's
overweight.
Okay.
Correct.
And then obese is
technically above 30.
Okay. All right. I know that the CDC is reporting that roughly 43% of Americans are now obese. That's a big number. If 43% of Americans are at a substantially greater risk of cancer, this is something that really needs to be on the front page of every newspaper, right?
Absolutely.
As I was reading that article and the others associated, one of the things they kept talking about is associated with a risk of. It was not saying causal.
Yes.
What is this differentiation? And we've talked about it before. What is the differentiation between association and causal linkage?
I'm not a biostatistics expert by any stretch, but those distinctions come down to the specific study designs that are employed. And so in this case, there's no real randomization that can occur, for example. So they didn't necessarily take these individuals at birth and randomize them to obese versus not obese, and then they followed them in that way. So from my understanding and my interpretation of this kind of conversation is that how you interpret the causality or the correlation simply comes back to what study design is being used. This is not a randomized control trial in which you have a placebo group and a active group. It is just different. So then, and that doesn't render the association that's made. It doesn't render it useless in any way. It's just that you have to then zoom out. Are there other papers kind of corroborating what's being said here? Are there mechanistic studies that are corroborating what's happening here? Or is there a whole subset of things saying the exact opposite?
Right.
So and then it also comes down to how well that this study, how well was the individual study or this individual meta-analysis done?
Right.
How effective were they in, actually answering the question that they were asking? So it's a long answer to say that even though they're not using the word causation in this context, it still means a whole heck of a lot because of everything else.
Yeah.
You know what I mean?
Yeah. So even though they're not using causal language, it is not something that can be ignored in the same sense that 100% of people who get in car accidents drink water. That makes no sense. There's tons of other data showing that has nothing to do with that. There's no other correlation there. Yes, that's true, but that doesn't make it a causal link. This is something where there's enough evidence repeated over enough periods of time with enough studies and all these things that we can fairly confidently say this isn't we're not calling it a causal link, but it sure looks like, it walks like a duck and quacks like a duck.
Mm-hmm.
Yeah. So the Washington Post says, experts note that being overweight or obese does not mean that someone will definitely get cancer, but rather that a cancer diagnosis is more likely than if a person had maintained a healthier weight. The CDC says, in addition to not smoking, keeping a healthy weight is one of the most important steps people can take to lower their risk for cancer.
Right.
For some people, this is like, you could read all the warning signs, stop signs, wrong way, don't go this way, do not enter. And people, like, what is it that's going to make somebody actually change to do? Like, people like to smoke. It's a way to cope. It's a stress reliever. People like to eat. Same thing.
Right.
Pain reliever or stress reliever, an escape. I just don't know, like, how many headlines like this are we going to read about lower obesity is lower cancer risk, and people still.
That's ultimately why the GLP-1 agonists, all these medications that are on the market now, have provided such an interesting alternative, an interesting, take on managing and treating diseases related to increased adiposity, because it's more than just there's of course the behavioral implication, but now we have medications that can help totally turn the behavioral component on its head.
Right.
So that in lies the problem, is that there's probably going to be more and more and more and more as far as associative links to cancer and various disease states with obesity. And that's still not going to be enough to drive any sort of change. I mean, you look at smoking and tobacco, all of these, policies had to go into place for things to start to change there.
Right.
There's still plenty of issues there.
Right.
And not saying that that's the same sort of circumstance, but it is just further highlights how complicated all of this is, really.
Do we have any idea? I mean, since we're not technically using causal language, but you mentioned mechanistic functions here. Do we have any idea of why this is? Why? I mean, it is not it doesn't make sense directly in my brain that obesity would lead to cancer. Mm-hmm. Do we have any idea of why we think this is happening?
We can go a lot of different directions with this.
Yeah.
But the three that were highlighted in this paper, I think, are the most useful. So the first underlying mechanism that they proposed has to do with sex hormone metabolism.
Okay.
The second one is insulin and insulin-like growth factor signaling, which a lot of these things are mentioned by Dr. Peter Attia.
Always.
In that camp. The third one is the the adipokine pathways or adipokine pathways. So instead of trying to parse each one of those out individually, let's just look at what's happening within obesity itself to try to make sense of this. Okay. So obesity is a clinical marker of insulin resistance and metabolic syndrome. It's associated with multiple biological metabolic changes, such as hyperinsulinemia, an increase in free fatty acid levels and triglycerides, and also low HDL cholesterol. So hyperinsulinemia induces a decrease in insulin-like growth factor binding protein 1 and 2, reduces sex hormone binding globulin levels, resulting in an increase in free estrogen and androgen, and also insulin-like growth factor 1 levels.
Okay.
So we mentioned those at the outset. That's sort of how those pieces go awry. So the IGF system plays an important role in normal growth and development, as well in a variety of pathological situations, particularly tumorigenesis, the formation of these malignant cells and tumors. Obesity is associated with an increased incidence of cancers arising from tissues responsive to estrogenic stimulation, including endometrium, breast, and prostate. And so...
And that's coming straight out of the study, right?
Mm-hmm. Mm-hmm.
Wow.
So it's a lot there. I figured that they would do a much better job at trying to explain and kind of, expand upon some of those fairly difficult mechanisms.
Am I right in hearing in that the greater the adipose tissue, the more aggravated those systems become, which then increases the likelihood of more adipose tissue? That it's almost a closed loop, like the hyperinsulinemia and those things that they encourage more fat storage.
Yes, exactly,
and that which then would make the situation worse, which is part of why it's so difficult for so many folks to reverse course on this.
Mm-hmm.
Okay, this is all real intense information. You're talking about people with greater risk of all-cause mortality in general having yet more negative news piled on top of them. What can we give people to help them in this situation? If you are somebody who is overweight or obese and you're going, you know what? That's it. That's what I need to hear. My grandpa died of cancer. My dad died of cancer, something like that. I'm done. I'm changing things. What can we suggest to somebody to help them get started on this path?
It's never too early to think about these sorts of interventions. It's never too early to think about a structured exercise routine. It's never too early to think about some of these dietary interventions that we talked about. It's never a bad time if maybe you fall in one of these categories that a GLP-1 agonist is suggested to you. It's not a bad thing to consider those, to be more open to all of these things. You don't even have to maybe fall into one of these BMI cut points that doesn't kick you out of this conversation.
Right.
It's never too late to start now, start yesterday.
That's literally what the whole point of this thing is that the sooner you make the change, the better. So the fact that you didn't start yesterday is okay. Start now.
Mm-hmm. And again, it's sometimes we get uncomfortable with aggressive interventions, aggressive caloric lowering. These GLP-1 agonists are very aggressive. It's this weekly injection, this pharmaceutical drug. There's many layers to that, of course, but when information like this continues to pile up,
right,
is it any wonder that aggressive early intervention sounds more and more and more appealing?
Right. Absolutely. That makes sense.
Sounds like one of those motivational posters with the cat on it, It's never too early. Start today. You know what I'm saying?
We don't have any cat posters at the website, but what we do have is a newsletter you can sign up for and keep up to date on everything going on here. You will find out about things like our Fall 20 sale, new episodes of this show, blog posts, all that stuff. We send it out in the email. That's on our website, askjoedimatteo.com. You can also find the show that started all of this, the Ask Joe DiMatteo Show, appropriate name. If you have a question, email it to us, questions@askjoedimatteo.com. Yes, you can use Facebook, you can use YouTube, leave a comment down below. Those all work too, but we like it when they come to questions@askjoedimatteo.com. Show notes, any articles that we mentioned are going to be available down below. And if you learned something from this episode, God bless you. But also, give us a like, give us a thumbs up, rate this thing 5 stars, share it to somebody else who needs to hear it. That sort of thing helps us so much. Big thanks, as ever, to Michael Deppish, our editor, Josiah Schweinberg, our engineer, Joyce Gibb, nurse practitioner who handles private consulting, Diane Silverman does product, Terry does scheduling, Cecilia handles distribution, and that's Dante DiMatteo. I'm Tyler Andrews. Have a great week.